The topic will be dose escalation strategies. Is there still a role for combining brachytherapy and external beam radiation in intermediate to high-risk prostate cancer? We should have said maybe intermediate and high risk. I'm lost. And who better than my colleague Michael Zelefsky can argue for the combination? He has been very instrumental in pushing forward this combination. So please, Michael, it's our pleasure to have you here.
Thank you, Mark. So thank you very much for the invitation to be here. And my charge this morning, as the title states here, is there a role for combining brachytherapy and external beam radiation in intermediate and high-risk prostate cancer? Well, is there a role? Of course there's a role for it. The real question is there greater efficacy or not? And ultimately, until we get the results of randomized trials, we really cannot say that it is established fact that one treatment is more superior than the other. But what I'd like to do this morning in these 10 minutes allotted to me would be to try to show you that there is potentially a great benefit in combining brachytherapy with external radiation to achieve optimal results in patients who likely need treatment, i.e. those patients who have intermediate risk prostate cancer. And we all recognize, and even the urologic community recognizes worldwide, the importance in radiotherapy of dose escalation, and especially among patients with intermediate risk prostate cancer and high risk prostate cancer. Randomized trials have demonstrated that higher radiation doses are associated with improved biochemical control outcomes at 5 and even in some studies at 10 years. And some studies have suggested an improvement in the distant metastases-free survival in these patients as well with the use of higher radiation doses. And you get the impression from looking at, again, these randomized trials that there is this continued benefit, and perhaps this benefit may even be seen if we move these dose levels into higher regions of escalation, which have never really been tested in randomized trials. But at least the curves suggest that as we would potentially move to higher radiation doses, and that's sort of been suggested by retrospective data, that we may indeed see even better results for patients who really need therapy that is intermediate and perhaps high-risk radiation, prostate cancer. Well, there are various forms of dose escalation. You could use high doses of IMRT. We push these dose levels to 86 gray. Standard certainly would be an 80 gray regimen delivered over about 9 weeks. But we could intensify this dose escalation by combining IMRT with brachytherapy, low dose rate, high dose rate brachytherapy, with IMRT generally at about a lower dose, 45 or 50 gray, or high dose rate brachytherapy as monotherapy. And here we have 2 randomized trials, and while we could quibble about the doses that were used, these are at least randomized trials comparing external beam radiation, somewhat in the study on the left, with a moderate hypofractionated or regimen or conventional regimen, to low dose rate brachytherapy combined with external beam radiation as well. And in the randomized trial on the right, a hypofractionated regimen compared to high dose rate brachytherapy and external radiation. And in both studies, we observe an improvement in PSA relapse-free survival for the combined regimens, that is brachytherapy combined with external radiation, suggesting that this combination regimen is achieving greater dose escalation and perhaps associated with an improved PSA relapse-free survival. In a retrospective experience from our institution, where we looked at high dose rate brachytherapy combined with IMRT versus high doses of IMRT to 81 gray, we observed this significant difference in PSA relapse-free survival with the combined regimen, suggesting as well dose escalation. It's not necessarily brachytherapy, but what we're seeing differences likely could be related to dose escalation here. And then recently published is where we have looked at our own experience with combining brachytherapy and external radiation versus high-dose radiation therapy to even 86 gray. And again, in this retrospective experience where we're looking at over 1,000 patients, we observe improved PSA relapse-free survival in the group of patients who had the combined regimen. And we also observed, which was surprising, with a follow-up now of 5 years, improved distant metastases-free survival outcomes in the group of patients who were treated with this combined regimen, suggesting that, once again, dose escalation for patients with intermediate risk prostate cancer is associated with improved outcomes. And here, a hard endpoint of distant metastases-free survival. Is the price there? We observed acute toxicity is higher in this combined regimen, but interestingly, and so far, and of course longer follow-up, as Dr. Sandler had mentioned, is of course important, but for now, late grade 2 and late grade 3 toxicities have not been significantly different between these two regimens. Finally, I at least bring to the point that maybe there's another benefit of combined regimens of external beam and brachytherapy with more intense dose escalation. We know randomized trials have taught us that for low dose or conventional doses of radiation, there's an importance in utilizing hormonal therapy in conjunction with the radiation. And here, these trials have demonstrated that when you use short courses of hormones with what I would say low-dose radiotherapy, there were improved survival outcomes. And it's, I would say, almost a standard of care to utilize short-course hormonal therapy with external beam radiotherapy for intermediate risk prostate cancer. But is that necessary when we use brachytherapy or intense dose escalation? And I would say that there's no role for using or proven role for ADT in conjunction with low-risk disease, we know that. And retrospective data suggests that there's a benefit using ADT with intermediate risk prostate cancer, even when we move to higher radiation doses like 80 gray. But there's no real data out there indicating that when you use escalated intraprostatic doses with brachytherapy and external radiation, that short course hormonal therapy is really necessary. And when we looked at our own data, with or without short courses of hormonal therapy in intermediate risk disease, with brachytherapy dose escalation, no significant differences in long-term outcomes. These data suggest that when you have combined regimens for intermediate risk disease, patients may not need that androgen deprivation therapy, which I would say is an appropriate use of hormonal therapy in this group of patients. And that may, in the long run, improve the patient's quality of life with obviating the need for any kind of hormonal therapy in this group. Of course, the RTOG study will hopefully answer these kinds of questions, because within this interesting study of 0815, which takes intermediate risk prostate cancer and randomizing them to dose escalation RT with or without hormonal therapy, as you see on the bottom, there is a cohort of patients that could either be treated with high-dose external beam radiotherapy or these combined regimens as well. And perhaps from this study we'll be able to ultimately learn more about which dose regimen may in the long run be better. So I'd like to conclude by saying dose escalation, we all recognize, is essential for optimal local control for intermediate risk prostate cancer. I believe integrating brachytherapy with external radiation provides greater intensification of the dose to the prostate. And this combined regimen, we've seen, at least in retrospective data, to be associated with improved biochemical control and distant metastases-free survival outcomes. Perhaps an additional advantage of this intense dose escalation for intermediate risk is that we may get away without the need for hormonal therapy. And hopefully in the years ahead, RTOG 0815 will help us address these issues in the years ahead. Thank you very much for your attention.
Thank you very much, Michael, for this excellent talk. And the counterpoint will be again by Howard Sandler. I myself also trained with Howard many years ago, so I can tell you that he's not an anti-person. He's very positive, but today he has to play the role of against in both debates. So you'll make the points against the combination. Howard, please.
Thank you, Mark. Nice to see you in Israel. It's my first time here as an adult, so it's really been a pleasure so far this week, meeting old friends. So I told Dr. Zelefsky last night at dinner that I was going to concede the debate right from the beginning, and I guess that's partially true. I said that, is there a role? Well, maybe there is a role, and I'll see if I can convince you for that. Well, let me just pause and just give give this slide and then give a few comments. This is a highly heterogeneous group of people that we're talking about. The debate is about the role of brachytherapy in addition to external beam for intermediate and high-risk prostate cancer. Now, these are the patients that we see in our clinic, at least in my clinic, on a regular basis. And it's a highly heterogeneous group, from a Gleason 7, 3+4 in a single core, to a Gleason 9 with 12 out of 12 cores positive. And so it's hard to make generalizations about the appropriateness of management. Management does often involve radiation therapy plus hormonal therapy in a significant subset of these patients. And what I won't talk about is the role of brachytherapy as monotherapy. Now, Dr. Zelefsky did show some small randomized trials in this space, but I've been the leader of the RTOG GU group for a long time, and so I have a fairly good sense about what we can do in North America as far as level 1 evidence randomized trials. And I'm confident that we are unable to do a brachytherapy versus no brachytherapy radiation therapy trial for many reasons, patient-driven reasons and physician-driven reasons. So we are going to be stuck, I think, for a long time, in contrast to my previous talk where we've got outstanding level 1 evidence that's emerging. In this space, we don't. And given that it's a highly heterogeneous group, I think the problem is that patient selection factors for treatment could play a dominant role in the report of a single institution experience. So Dr. Zelefsky treated some patients with external beam and some with a combination. Well, why did he treat some with a combination? And why did he treat some with external beam? He probably knows. He could probably tell us how he selected those patients. But there would be factors that would be unknown even to Dr. Zelefsky for how a patient received one treatment or another. And those factors could have an important influence on the ultimate outcome, the disease outcome, or the toxicity outcome for the combination. Given that there's no level 1 evidence, groups like the NCCN are unable to make firm recommendations in this space. And in the intermediate risk space, if you look in the middle, they are quite, they vacillate quite a bit, because they say RT, which is external radiation, plus or minus ADT, plus or minus brachytherapy, or brachytherapy alone. So you want to do any radiation combination, NCCN will support that in intermediate risk cases. And for high risk, similar, although brachytherapy alone is not an option, but radiation plus ADT is their category 1 evidence, but they also indicate that radiation plus brachytherapy with or without ADT is an option as well. So NCCN doesn't know the right answer to our debate. I show this slide with some hesitation. I don't know if any of you have seen this before, but there's a radiation oncologist, a brachytherapy guy in the US named Peter Grimm, who's put together a number of experts, including Mike Zelefsky, and I don't really understand his methodology. I'm not part of this group. But what he does is he puts all of the published literature together using this format where the PSA progression-free axis is on the y-axis and the years of follow-up is on the x-axis, and each dot is one paper, one published experience. And then he draws these circles that kind of give you a gestalt for the biochemical control for a given modality. And external beam doesn't fare very well in this curve, and brachytherapy does. Now, Dr. Grimm is a brachytherapy person, so there's probably a little bit of bias there, but presumably this is a valid report of what's in the literature, but it's a methodology that I don't think we can consider to be totally validated. And similarly for high risk, but even though the shape of these curves might give you an impression that brachytherapy is better, there's a fair amount of overlap, and there could be valid reasons why one particular external beam study drags down the curve or so on and so on. So there is a suggestion that maybe, as I said in my title slide, that maybe brachytherapy could be indicated. How is RTOG handling this? We have to write trials without knowing whether brachytherapy adds anything or not. We've got to continue. And I've already told you that I don't think we can do a trial plus or minus brachytherapy in a randomized sense. So we just threw up our hands. We said, we don't know what's best. If you want to do radiation, it has to be high dose, and it can be with external beam to high dose, or it can be with an LDR brachytherapy boost or an HDR brachytherapy boost, because we don't know. And Mike already indicated that this study is ongoing, and it's really testing whether hormonal therapy is of benefit. That's not why I'm showing it, just to show you that if you look in the lower left, all RT modalities are allowed. And if you look, as this trial has accrued, so far over 1,000 patients, there's the vast majority are external beam alone. And it's probably less than 100 are combination, indicating at least if you vote with your feet, so to speak, if you vote by what you do, the vast community of radiation oncologists who participate in RTOG in North America believe that dose-escalated external beam is acceptable in this space. Now, I'm kind of a prisoner by what I've published, and I'm a co-author on this paper here, published in Cancer in 2013, and it says the addition of LDR brachytherapy and ADT decreases biochemical failure and decreases prostate cancer death compared with dose-escalated external beam radiation therapy alone. So I've published on this, and I've published a paper that says that brachytherapy is a good thing. And here are just the money curves from that paper. The upper one compares, on the y-axis, prostate cancer-specific mortality. So just like Mike Zelefsky suggested that brachytherapy reduces distant mets, this suggests that brachytherapy reduces prostate cancer-specific death by a small amount at 10 years, a few percent. And interestingly, if you look at the bottom, there's no difference whether men got ADT or not. So suggesting, if anything, that in this high-risk patient population, brachytherapy is more important than ADT, which is not what one would have expected up front. So for the question at hand, is brachytherapy necessary for the treatment of intermediate or high-risk prostate cancer? Necessary? No, I don't think so. Is the hypothesis that brachytherapy improves outcome a reasonable one to test? Yes, I think that's a good hypothesis. I would love to test this. And I don't think it has been adequately tested yet. Will RTOG test this hypothesis soon? No, we won't. And that's where I'll leave it for the debate. Thank you.